Hello, welcome back. Today we're going to continue on our journey through the respiratory tract, and today we'll be landing in the lower respiratory region. So, of course, the lower respiratory region is going to be made out of the larynx, and it's made out of the respiratory epithelial mucosa on everything except for the lingular surface or the epiglottis and the vocal cords. So the lingular surface is going to be the tongue. It's covered by other things, of course. The epiglottis is while vasculated, here as you can see here, it doesn't actually have any mucosa, and neither does the vocal cords, of course. So they have the non-characterized stratified squamous epithelium in order to protect the folds and the other structures from abrasion. Abrasion from what? Particulates when you inhale, food particles, also water. The water will strip the mucus. The vestibular folds over here, they're going to have the glands that will trickle down. They will produce the mucus, and that will trickle down to lubricate the vocal cords. The vocal cords themselves are bare. The ligaments are made out of the elastic fibers because these are the ones that can, contract and move in order to adjust the tension of the vocal folds. And the lamina propria of all these structures will have diffuse, as you can see here, nodular lymphoid tissue. So there's going to be the lymphoid nodules, not the nodes, sorry. Along with a bunch of seromucous glands. So this is the difference between a vocal cord, or the true vocal cords, and the vestibular or false cords. As you can see here, they're stratified. There's some septa here, but there's no actual mucus producing cells. Here, there's a lot more structures. Here are the nodules, and down over here would be the seromucous glands. So hoarseness can come from a variety of different, etiologies, but the most common etiology is the acute laryngitis, which is usually a viral infection. So this can be strep throat or mono, and that causes basically purulent secretion. That's one of the main, clinical signs, along with the sore, painful, hoarse voice, sore, painful throat. On the other hand, you can develop vocal nodules, and polyps from overuse, and these usually come from singers, Broadway singers, operatic singers, anybody who sings for a living, along with anybody who speaks dramatically for a long period of time, kind of like live play actors. And this is also caused by irritants and caustic substances. So if you don't wear a proper mask and you mine or you are a welder, this will cause the nodules or the vocal polyps too. But people who inhale a lot of irritants and caustic substances usually develop a granuloma instead. And granuloma is benign, and those can be caused also by GERD if it's particularly bad and it goes past the esophageal sphincter, and it can also be caused by trauma. And GERD causes the granuloma because the acid from the stomach will erode the mucosa and cause the stem cells to proliferate too fast and too much, and then they will, bulge forward, causing the granuloma, which will press onto the vocal cords, causing hoarseness. So usually these patients come in, and when they don't really complain of it unless they're a singer, but if you are, a clever physician, you ask very detailed questions and ask, has there been any changes in your voice? They would say oh yeah, I've been having a hoarse, kind of raspy voice, and they also present with a lot of throat clearing to try to clear up the hoarseness, even though there's no mucus in their throat. So then you would do like a bronchoscopy in order to see the granuloma. Okay, so in the trachea, there are goblet cells that are more abundant in the beginning of the trachea, and then they get less in the lower trachea. The problem with the trachea is if you have GERD, and the irritation will cause the epithelium to be replaced too fast, and instead of replacing it with normal cells, the stem cells will replace the normal like columnar cells with stratified squamous epithelium. So it begins with squamous metaplasia, and then that can, if not treated, evolve to dysplasia, which is like the precursor to tracheal cancer. So the lamina propria is, as you can see here, is usually loose and is vascular. It has elastic fibers, of course, because the trachea is mobile, along with the seromucous glands in order to lubricate the trachea and like kind of prevent antigens or pathogens from binding onto the trachea and getting, invading. And they also have a lot of MALT, which is mucus associated lymphoid tissue, of course, because this is a canal that opens to the outside. This is like, the lumen. And of course, things from the environment can penetrate in. So we want the MALT there in order to like stop the pathogen in its tracks and not allow you to be infected. But sometimes our immune system isn't quite fast enough, and that's why when you get sick with like a cold or something, this is like the first place it penetrates. It goes through the walls of the trachea into the bloodstream, starts proliferating, and that's why you get a sore throat. So the submucosa below will have the seromucous glands, and then the trachea has the C-shaped hyaline cartilage. So here's the glands, here's the cartilage, and the cartilage is there to provide shape, but in the back it's open, so the bolus of food when it passes down the esophagus can, stretch and not it can not disrupt the trachea too much, but it will also compress it. So sometimes when you take too big of a mouthful of water or food, you can feel kind of breathless, and it's literally because your trachea is closing off. So the trachealis is a smooth muscle, and it constricts and narrows the lumen in order to raise the intrathoracic pressure during coughing. So how does it do that? So it constricts and narrows the lumen, and it closes the epiglottis, which makes the intrathoracic pressure rise high enough that a reflex will cause you to expel the air in order to breathe. And the trachealis also works to relax to allow food to pass. As you can see here, bulges, and the fibroelastic sheet of the esophagus is continuous with the perichondrium. Wait, I'm sorry, not the esophagus, the trachea. It has the fibroelastic sheath, and it connects the cartilage with each other, and that allows the lengthening and shortening during movements of the neck, because it would be pretty problematic if the trachea can't move every time you nod or turn your head. And the outermost adventitia is going to connect the trachea to the surrounding structures. And right beside the trachea are the thyroid gland, and then right in the back is the mucosa. Okay, so we've gone through the trachea, and then it goes down into the main bronchi, and then from the bronchi it separates into the lobar bronchus, and then the segmental, and then the terminal bronchi, and then from there it goes and divides even further until it reaches the alveoli. So the main bronchi have still the true columnar cells, but this time they have denser lamina propria and more glands. So they have more glands, and then it decreases as you go further into the other divisions. It also has a discontinuous layer of smooth muscle and MALT. And then the submucosa is characterized by plates instead. So you go further in, and their cells shrink. First, they're true columnar, then they're like a little shorter, and you have less like secreting cells, like goblet cells. And as you go further in, the amount of like lymphoid tissue will increase. And then the smooth muscle will also increase. In the bronchioles, it's kind of formed after the 10th division of, bronchi into lobar, into the respiratory, and then the terminal, and then all of a sudden you get to like, well, not all of a sudden, after 10 divisions, you go into the bronchioles. They're really small, and the larger bronchioles have epithelium made of pseudostratified columnar. So they're getting shorter and shorter, so they're not stratified anymore. They're pseudostratified layers of cells, and they're ciliated with few goblet cells, and they have clara cells, like more clara cells. So the lamina propria, of course, like I said, didn't have any glands, and instead they have more elastic and smooth muscles, which make the folds in the mucosa. Here's the folds. It's going to be the smooth muscle surrounding it, and eventually they kind of like, decreases to just be like a few strands in the respiratory bronchioles. And when you breathe, expiration will compress the bronchioles and inhalation will expand. All right, further in. So here's your alveolus, which is like, the smallest one, the smallest unit. Here's the sac. You can barely tell this is the duct. So you can see duct. And then the respiratory bronchioles, and then here's the terminal bronchioles, the bigger one. So the transition from the terminal bronchioles to respiratory bronchioles is like the low pseudostratified columnar cells to a low cuboidal epithelium. So the terminal bronchioles are going to be the last of the conducting portion, and then the respiratory bronchioles is going to be like the beginning of the respiratory portion. So there's not any goblet cells, clara cells are going to predominate, and there's only a few smooth muscle fibers. Further in, alveolar ducts, they're going to be tubular structures, and they have continuous branches, so they're not interrupted. They're lined by very thin squamous epithelial cells, and they end in the alveolar sacs. And then the opening of the alveolar along the walls of the ducts will allow, passage of cells, really. And each are surrounded by a smooth, like a single strand of smooth muscle and a few elastic and collagen fibers for structure. So the sacs are going to be clusters of alveoli, and they are still covered by a lamina propria, and inside the lamina propria there are capillaries. So the capillaries are going to lead into the veins, and they have a few elastic reticular fibers. Okay, so further in you get the alveoli, and they are very, very small, and we have many alveoli, in order to increase the surface area of the lungs and thus receive more oxygen. So the alveoli are going to be surrounded by capillaries, and they're lined by the type 1, type 2 pneumocytes. Remember, type 1 is just like a barrier cell. Type 2 is going to make the surfactant, or the molecule, or like the component of the phosphatidylcholine component of the surfactant, and they're all separated by a septum, but there are going to be pores in the septum in order for like a cellular exchange. So if anything comes, like a pathogen comes, a white blood cells can come in and squeeze through the pores in order to take care of that. So here's the outer alveolar sac membrane, and here is the septum, here's the septum, here's an alveolus, and all of this would be like in the alveolar sac. Alright, type 1 cells, they're going to be the simple squamous epithelial cells. They make almost half of the total amount of alveolar cells, and they really are there to form a barrier. They are terminally differentiated, so once they die, they die. They can only be replaced by the stem cells, like migrating to the surface. And there's a flat nucleus, so remember flat, and then some organelles. They have a lot of penocytotic vesicles in order to control the amount of surfactant, which is dependent on the amount of water. And then they have desmosomes and occluding junctions, of course, to isolate the cells and prevent anything leaking or undesirable leaking across. And they are replaced by the type 2, which is going to be the stem cell once they are damaged or they are old. And they're replaced every like 3 to 4 months, so they do have a decent lifespan. So the type 2 cells are going to be cuboidal cells, and they make up the majority of the total alveolar cells, and these are self-renewing stem cells. So they are attached to the type 1 cells by desmosomes and occluding junctions, and the nuclei is going to be larger and rounder. So remember, this is a differentiating factor. The type 1 cells are going to have a flat nucleus. Type 2s are going to be round. The cytoplasm have the Golgi apparatus here, and a lot of mitochondria, vesicles, and laminar bardae, which make the cytoplasm eosinophilic. They make dipalmitoyl phosphatidylcholine. I can never remember that word, but DPPTC, and that is a component of surfactant. And they have numerous microvilli, but they don't have any granules or anything that releases proteases. So this is going to be DPPTC. Type 1 cells and the capillary endothelial cells make the blood-air barrier, so as the cells along with the layers. And the fused basement membrane of the capillary endothelium fuses with the type 1 cells, so they're not going anywhere. And they allow only air into the alveoli and ducts. You can see here is the blood-air barrier, and here waiting along the slides are just the type 2 pneumocytes. Here the type 1, they're flat nuclei. Blood will go here, oxygenated, and then the macrophages are all floating around just to prevent infection. So the alveolar septa separates the they just separate the alveoli from each other, and they're made out of fibroblasts and macrophages and neutrophils and mast cells. And all of that is supported by a net of capillaries and elastic and reticular fiber. And these fibers allow the support and recoil of the alveoli, especially when you breathe. Remember when I said they compress and then they expand in inspiration and expiration. And the interstitium of this is going to be made out of the interalveolar septi. And the interstitium is going to be affected in inflammatory and fibrosing conditions. So interstitium should be, as you can see, flexible and elastic, but in inflammatory and fibrosing conditions they become very stiff, so it takes a lot more effort to breathe. Here are this is a sick person, and the alveolar walls should be relatively thin, but there's going to be fibrous microthrombi, so clots in the alveolar capillaries in this person. So clots here, clots here, clots here. Problematic because it interferes with the exchange of oxygen and carbon dioxide. Okay, so macrophages and neutrophils will release elastase to deal with pathogens. Unfortunately, they also break down the elastic fibers of our own interalveolar septi. Luckily enough, we have a backup system in our body. It's called antitrypsin in order to neutralize the elastase. Emphysema is going to be a loss of elasticity, and it's usually prevalent in patients who have a congenital or genetic disorder where they are deficient in antitrypsin. So without the antitrypsin to neutralize the elastase, elastase breaks down the alveolar walls and enter alveolar septa, and the body replaces those with something a little bit stronger to resist the constant breakdown, and unfortunately that is going to be fibers. And of course, because of the fibers, there's not going to be a lot of expansion available, because this is going to be like a fibrosing condition. So pneumoconiasis is going to be an excessive stimulation of fibroblasts, and I just described that. And then the interalveolar septa are going to be penetrated by alveolar pores of cone, and those connect the alveoli to different bronchioles. And by doing so, it allows the equalization of pressure between alveoli, but unfortunately, it's also a route of infection. Okay, pleura. We went through this in anatomy, but just to go through it again, it covers the lungs. There's going to be the visceral layer and the parietal layer. Visceral, of course, is going to be inner, parietals outer. And inside the pleural cavity, it should be negative. In a punctured lung, in a pneumothorax, the lung is going to be collapsed, and then the parietal pleura is going to be separated by the visceral pleura by quite a lot of space, and that usually fills up with like fluid. Okay, that's it for now. Thank you for your attention, and good luck studying.